So next is paraesophageal hernia. It's V12. 58-year-old female presents in clinic with 2-year history of retrosternal heaviness and discomfort after eating with intermittent dysphagia. She is on long-term management with proton pump inhibitor therapy. A gastroscopy and barium swallow reveal an 8 centimeter paraesophageal hernia. How do you define hiatus hernia and what are the management options? Hiatus hernia is mostly classified on endoscopy findings. Type 1 hernia is sliding hiatus hernia in which the esophagus and variable portion of the cardia protrude into the thorax and are the most common 90%. Type 2 paraesophageal hernia where esophagus and cardia remains in the abdomen but the cardia remain but the stomach has herniated through the diaphragm. And type 3 is mixed type in the abdominal esophagus as well as the gastric cardia and fundus protrude into the thorax through the enlarged hiatus. And type 4 refer to a large defect hernia with other organs such as colon and small bowel protruding into the thorax. The management options include medical management. For type 1 hiatus hernia, the proton pump inhibitor device such as elevating the head end of the bed, stop eating late in the evening, smoking cessation, avoiding unnecessary coal and coffee and other food stuff worsen reflux may help. Current recommendation is that all symptomatic type 2 and type 3 hernias should be out surgery if they're fit. The principles of esophageal hernia is excision of the sac, reduction of the herniated stomach, and 2 to 3 cm distal esophagus, and repair of the diaphragmatic hiatus, and anti-reflux wrap. If this hernia is not done, they have 30% mortality in emergency and 1% elective. And in emergency, then patient has to go through laparoscopic repair, endoscopic repair plus minus PEG. She has had pH and high resolution manometry done prior to referral and the Demister score is normal. She has been told this means that she has no reflux. Would this impact on your management? In large paraesophageal hernia, the pH study is frequently normal as the probe is extremely hard to place accurately and should not have impact on decision making in these types of hernia. And manometry can be helpful to plan a full 3-degree infinite equation or partial wrap. What is the recurrence rate of hiatus hernia? Should mesh be placed in these repairs? In all these patients having this surgery, 50% have a small recurrence on imaging at 5 years. And mesh, again, controversial thing. If you're using absorbable mesh, it has high recurrence. If you're using non-absorbable mesh, they can erode into the esophagus. The placement mesh reduces the recurrence rate at the risk of mesophilic erosion, potentially in the esophagus. 24 hours after surgery, this lady has significant bout of coughing and now has severe retrosternal pain and dysphagia to solid. What do you think is happening and what would the management be? So first of all, I will make a nil by mouth fluid station and I will do a chest x-ray to see has the fundoplication has slipped up. As the stomach has remained in the thorax for a long time, it can easily slipped up. And if chest x-ray is not clear, then I will do a CT thorax and confirm this dissection of the sac from the thorax and partial or complete removal can reduce this complication, particularly in the immediate postoperative period. Reoperation is necessary and this can be done laparoscopically. If the situation is not dealt with, herniated stomach and wrap can become incarcerated and stomach blood supply can become compromised. The defect has to be reassessed and repaired either primarily or using a mesh. The placement of a PEG tube has been used to help anchor the stomach in this particularly if the defect is very large and the whole stomach has been in the chest. Thank you.